Welcome back to EducateMe MD. I am Dr. Sara Sultz, a general pediatrician, and today we will continue our series of a newborn who is almost ready for discharge. We will discuss the hearing test, the car seat check, and discharge planning. This is an exciting time because it usually means the baby is doing well and ready to go home. I will go into uncommon depth on common topics to explain the ordinary in a new way, so please join us. Hello, and thank you for being here today. I'm very excited to be back with you. I want to start by bringing an update on the baby girl we've been following. She's now 2 days old and it's time for a discharge from the hospital. Parents have brought her car seat in to be checked, and I've returned to their room to give the discharge talk. A hearing screen was attempted yesterday, and she passed on one side but not the other. It was repeated this morning, and she passed on both sides, which the parents were very relieved to hear. She does not have any risk factors or a family history of hearing loss, so no further testing is recommended. Today I want to start with a more in-depth discussion about, you guessed it, the newborn hearing screen. It is law in all 50 states that babies have their hearing checked before going home from the hospital or birthing center. The laws have been set by the states themselves, so there is some variability, and in Texas, the law was updated in 2020 to clarify some of the terms and to add a consent form to make sure parents are fully informed about the testing and expectations. Not all birth facilities follow the requirement to test hearing, so you can always ask your doctor if your baby will be screened for hearing loss before discharge or how to have it done after discharge. You want to know as soon as possible if your baby's able to hear you say, "I love you." So about 3 out of 1,000 babies are born with significant hearing loss. This is fairly high frequency for a single issue, and the hearing loss can be from a genetic syndrome that occurred spontaneously during development or passed down in a family called familial. Hearing loss can also be from an infection either before or after birth. The most common infection before birth is called cytomegalovirus, CMV, and that's one mom can get when she's pregnant that can cause significant issues with hearing and vision in the baby. And the most common infection after birth is a bacterial meningitis that causes infection of the brain and spinal cord and can affect the hearing. There are also medications that mom or babies may be given that could affect hearing, especially ones like gentamicin and vancomycin, and even hyperbilirubinemia that we talked about in the last episode at high levels can affect the hearing. There are 2 different tests commonly used, and I want to explain them briefly. The first is OAE, abbreviation for otoacoustic emissions. And it's done with a small probe that's placed in the baby's ear canal, and a sound is made by the machine. Then the machine picks up a very tiny vibration and sound from the cochlea. The cochlea is a tiny spiral-shaped structure deep in the middle ear, and if there's damage to the cochlea, then that can definitely affect hearing, and that's what this test would pick up. It is pretty accurate, picking up about 70 to 90% of one type of that cochlear hearing loss, and it can miss about 1 to 3% of cases. This means that some babies with normal hearing will have an abnormal test, and that could be from fluid in the ear canal, it could be from the anatomy of the baby's ear canal, too much noise in the room, and so we have to make sure that we have ideal conditions, that the baby is quiet, the room is quiet, even machines in the room can sometimes create too much noise for the machine to hear it. So that's why our baby at the beginning didn't pass on the one side. It's kind of presumed due to one of those things, but then the next day she passed, which was great. This can lead to frustration when babies consistently don't pass their hearing test. And I remember one family that had a baby that required follow-up for several months, ultimately to be told their baby did not have any hearing problems, which obviously was great, but they were hesitant to test their second child because they were worried they'd have to go through the same thing with several visits to just be told that she's normal. We discussed the risks and benefits, and ultimately they did decide to test their second child, but I understood where they were coming from. It's tough because with most screening tests, it can cause some anxiety and it will also miss some kids, but for the most part, it works really well and picks up a majority of the kids we're looking for, so it's been shown to be a consistently good way to test for hearing loss. There is a second test called the ABR, which is Auditory Brainstem Response, and this one is done by placing different electrodes on the baby's head and measuring the brain signals in response to noise. So obviously this is looking more for that neurologic type of hearing loss where we're not getting the right information from the brain to the ear or back from the ear to the brain. So it does not just pick up cochlear hearing loss. It's more accurate, but also requires more time, and not all facilities have the equipment to do this test. Almost all babies in the NICU will have an ABR before discharge because they're at more risk than a term baby born in the hospital. And they may do an ABR if a baby fails an OAE or has certain risk factors such as family history or was on those medications like I talked about. So the newborn hearing test is important, but obviously even a baby who fails a hearing test and has hearing loss is not going to function any better if they don't have good follow-up and intervention on that follow-up, right? So mostly this is done through hearing amplification with things like hearing aids or cochlear implants and speech therapy, but I'll leave further discussion about those for another day. The data I found about the timing on this really surprised me. If a baby can get diagnosed and start intervention before they are 6 months old, it makes a huge difference, not just in their speech, but their cognitive outcome, which means how well their brain functions and works for the rest of their life. This 6-month cutoff was consistent in several studies, and especially the work by one lady, Christine Yoshinaga-Itano, who worked on creating a high-quality early intervention program in Colorado for several decades. She was the example for the rest of the country to develop programs in the 80s and 90s, and she showed that if you early identify and have good follow-up, that 80% of the population can have normal cognition. This was incredible. It was regardless of their functional status, meaning what other syndromes or disabilities they had, and it's so much higher than the cognition level of kids with hearing loss that was picked up after 6 months. So prior to newborn screening, kids were often not diagnosed with hearing loss until they were about 2 years old or much older, and they didn't get hearing aids until they were at least 3 years old. And by then they may have missed the critical period for developing normal speech and understanding, so you can understand that their brain wouldn't function as well potentially if they hadn't developed those other skills. Obviously there are some kids and families that remain deaf all of their lives and never hear properly, but they are often known that within that family that's a higher risk, and they're still taught sign language and other skills from a very early age that allow them to have normal brain development as well. So obviously you can tell that I think screening all newborns for hearing loss is important because a lot of kids with hearing loss don't have any risk factors, and early intervention makes all the difference. So now I want to move on to discussing an amazing innovation in safety, that infant car seat. I know it doesn't seem very glamorous, but luckily it's been accepted as essential for all children that want to travel safely in a car, bus, or even plane. A car accident happens in the U.S. every 60 seconds, with over 6 million accidents every year, and most people will be in 3 to 4 accidents in their lifetime. So this is obviously a very frequent problem. The very first car seat was made in the 1930s, but it was not for safety. It was so kids could see out the windows in the car and also not climb around the car and distract the driver or other people. The first seats for child safety weren't created until the early 1960s, one by Leonard Rivkin in 1963 in Denver, Colorado, and one by Jean Ames in 1962. She was a British journalist and mother. So you can see car safety was on their mind as similar designs popped up in different countries around the same time. And in the 1970s, they were in pretty regular use and some federal standards were created. But it wasn't until 20 years later in the mid-1980s that all states finally had a law that required people to use car seats and to keep babies rear-facing until they're 1 year old. This law stayed in effect in Texas until 2009, when it was updated to say that all kids under 9 years old and shorter than 4 foot, 9 inches must stay restrained in a proper child safety seat or booster seat while the vehicle is in motion. The current recommendation that infants should stay rear-facing until they are at least 2 years old or even up to 3 is not written in the law, but a strong recommendation from the American Academy of Pediatrics. Rear-facing in the back seat is the safest way to travel, so we want to keep our most precious cargo safe as long as possible. This is a critical stage in baby's development because their bodies are still so fragile. So if you take an x-ray of a baby's hand when they're just born, you will see just like 2 small bones. In our hand, we have multiple different bones that push into each other, and a baby's hand may feel like it has bones because they're mostly made of cartilage, but there's not much solid bone. So if you take an x-ray of a baby's back, it's the same thing. Their spine is not fully developed. Those vertebrae, even though you may feel a backbone, is still very fragile, and that puts their spinal cord and brain at much greater risk if they're in an accident. So combine this with their proportionately larger head compared to body size, that if you're forward facing, you have a lot more of this kind of motion, a much higher risk of damage to the neck. And that could lead to paralysis and obviously other neurologic problems if you have a spinal cord injury in a car accident. This bone development process is slow and gradual and can vary from child to child, which is why it's difficult to set a specific age on when to turn them around. It's not because their arms and legs are too long, because I hear that a lot. We'll wonder if their feet are pushing against the seat. They can hang their legs over the side, but you do want to make sure that they're in a car seat that can properly accommodate their height and weight. But we really keep them rear facing to protect the head and spine. So I may go into more depth on car seat installation and how and when to transition a baby from one seat to another in a later video, but right now I want to focus on the newborn ready to go home from the hospital. It's important parents have a seat that works for the baby's size, right? Like I said. So if they're only 5 pounds, not all newborn seats go that low. It's also important to make sure that the car seat's not recalled and has never been in an accident. I strongly recommend buying a new car seat for your baby, but if you do get a used one, make sure you check online for a recall and ask questions of the person you're getting it from about prior accidents and things like that to make it as safe as possible. When babies are born premature, they often do not fit in car seats as well, and their neck muscles are also weaker, so they're more at risk of dropping their chin to their chest and could stop breathing, especially if they're too upright and not nicely reclined. So most hospitals require a family to at least show how they will secure their child in the seat before discharge, especially if it's their first child, and maybe even have the baby stay in the seat for 30 or 60 minutes while connected to a monitor to make sure that they don't have any pauses in their breathing during that time. So the next step after you've chosen a seat that fits the baby well is to make sure it's properly secured in the car. And this can vary for different seats, so it's important to make sure you know how to do this before you're ready to bring your baby home, and if at all possible, to have the installation checked by a professional in your area. They can sometimes be found at the fire department, the hospital, or a community center. I remember trying to find one after my first baby was born, and it was actually harder than I expected because some communities only do checks at specific events and things, but thankfully with resources like online videos, people can feel more confident in the installation even if they can't find someone to check it. So you never want to put a car seat in front of an airbag, and the safest location is in the center of the back seat. But if your car does not have a back seat, then make sure the airbag on the passenger side is turned off. One of the most common mistakes made when securing a baby into the car seat is that the chest strap that buckles right across the chest is not high enough, and a baby could potentially get their arms out or slip out in the intense force of an accident. So make sure that chest strap comes all the way up to their underarms. Car seats are one of the best safety inventions, but the leading cause of death for kids aged 1 to 12 is still car accidents. So do your research, make sure you're using a good seat in the best way possible. It doesn't have to be the most expensive, but it needs to be right for your child and installed and used correctly. All right, so the last thing I want to mention today is the discharge instructions. At first, I wanted to give my whole talk, which is usually about 10 minutes by itself, but I'm just going to give a few highlights and remind parents to pay close attention to the details they're given to know what is normal and abnormal for a newborn and what to do when they're concerned in their area. A lot of facilities will also give a handout for the sleep-deprived parents who may not hear a lot of what is being told before you're ready to go home, so make sure to read those as well. Basically, this discharge talk covers expectations for feeding, for sleeping, back is best, diaper changes, and safety, like the car seat, and any specific topics for that child. Also, I review umbilical cord care, so you don't need to apply rubbing alcohol at every diaper change. In fact, not cleaning the umbilical cord except for sponge baths is totally appropriate. You want to watch for any signs of infection, so concern for a high or low temperature like we discussed in episode 4, and signs for mom and dad on emotional well-being, postpartum depression, those sorts of things. The obstetrics team will be the one to give mom instructions on postpartum care, when to follow up. Babies are usually seen either at home or in the hospital 1 to 2 days after discharge to check their weight and bilirubin levels. And their next visit's usually at 2 weeks to make sure they've regained their birth weight and see if everything is going well. Mom's next appointment is usually at 6 weeks. And so this may seem obvious, but to a new parent, it's all new and can be overwhelming. So just take one step at a time. And remember, it's okay to ask lots of questions and to get help as needed. I love sending babies home, and even sitting here now, it makes me feel excited and a tiny bit anxious as I think of all the newborns that are starting a new life with their family and what the future will hold for them. I could go on, but I want to finish this episode, so thank you for listening. And I even learned something when researching these topics about the origin of the nation's hearing screening program and the progression of car seat safety, so I hope you did too. Please, if you find these episodes helpful, hit the like button, subscribe, and even leave a comment so I can learn who is watching and hopefully enjoying my videos. Thank you for listening to Educate Me, MD. I am Dr. Sara Sultz. God bless and have a great day. Quick disclaimer, the information contained in this podcast is strictly informational, and even though I am a doctor, I am not your doctor, and you should always consult with your own healthcare team before making significant changes to your care. Thank you.